In 1988, the World Health Organization made a film based on a lecture by the obstetrician Professor Mahmoud Fatala. Its aim was to raise awareness of the millions of women and babies dying each year from pregnancy and childbirth. The film told the story of one such mother, Mrs. X. It was called, "Why Did Mrs. X Die?" Since then, there have been significant improvements in maternal health, yet by no means enough. In some places, things have hardly changed. Women and their babies are still dying needlessly. This is why the story of Mrs. X must be retold. This is the story of a mother called Mrs. X. Mrs. X could have come from anywhere, but she is most likely to have come from a low-income family in a poor country. Mrs. X represents a universal mother. Mrs. X died in a small hospital, 8 months pregnant. The doctor had no doubt about the cause of her death, a hemorrhage. Her placenta had been too low down in her uterus and hadn't been identified in time. The doctor recorded her death, closed her file, and added it to a growing stack of similar cases locked away in a cupboard. Over time, these stacks grew and grew. Some years later, worried about the high numbers of mothers dying in their hospital, the staff reviewed the cases to learn lessons and make improvements. They reopened and reviewed file after file. One of these was that of Mrs. X. When they read it, they found two striking points. First, Mrs. X had arrived at the hospital bleeding heavily, yet she only received half a litre of blood. This was all the hospital had available, and it was not enough. Second, Mrs. X and her baby needed a caesarean section, but resources were limited, and the operation took place 3 hours too late. Both Mrs. X and her unborn baby died. The group then visited Mrs. X's village and spoke with her family, neighbors, and community leaders. They found that there were other reasons for her death. Mrs. X had a history of bleeding early in pregnancy, but wasn't aware that this was a danger sign needing attention. She also had had only one antenatal visit. If she'd gone regularly, her problem may have been picked up. She would have been referred to a specialist, and she and her baby could have survived. Mrs. X was also severely anemic, so the loss of even the smallest amount of blood, as little as a cupful, could have tipped the balance between life and death. The team discovered that it had taken 6 hours to collect enough money to pay for her transport to the hospital. As a result of these findings, the hospital improved their blood supplies, updated their emergency procedures, and caesarean sections could now be performed as soon as was necessary. The local health department provided more midwives in more places to enable more women to have access to good maternity services throughout their pregnancy and birth. Mrs. X's file was closed again. A year later, a group of visiting health professionals came to the hospital as part of a national inquiry into maternal deaths. They wanted to understand what lay behind the statistics, beyond the numbers, and discover the wider social and economic reasons for the deaths of women like Mrs. X and their babies, and what could be done about it. The aim of their work was to recommend changes to the national or regional policies and strategies to improve women's health and to save mothers' lives. When they reviewed all their data, common patterns emerged. They found most mothers' stories were similar to that of Mrs. X. Like many women in developing countries, Mrs. X worked day and night to care and provide for her family. She was illiterate. She lived in poverty in a remote village. she was unable to choose when and if to become pregnant. Mrs. X was also weak and unhealthy. In her society, the male members of the family came first in the queue for food, for education, and for healthcare. Mrs. X often went without. For women like her, death or complications in pregnancy were, and still are, a real threat. By uncovering the stories of women like Mrs. X, the national team were able to put pressure on the government to provide more education for girls, more resources and staff for maternity care, and better reproductive health services. They also pushed for raising community awareness about health, nutrition, family planning, and the benefits of skilled maternity care. Mrs. X started on the pathway of her pregnancy exhausted, with few physical reserves. She hadn't chosen to become pregnant. It was her destiny. The only value she had to her family and community was her ability to produce children. However, Mrs. X had been lucky in a way. At least she'd had a childhood. In some societies, girls are married off while still children themselves, not physically or mentally prepared for childbirth or motherhood. If Mrs. X had been treated as an equal to her brothers while she was growing up, she could have been healthier and better educated. If she'd had more control over her adult life, she may have been able to choose when she had children. As Mrs. X continued her walk through pregnancy, her prospects would have been better if she had visited a skilled professional health worker, a midwife or doctor. Even if Mrs. X had known the importance of antenatal care, her midwife was many miles walk away. If only Mrs. X's problems had been recognized and her anemia treated. If only she'd had specialist care in time. Because of tradition, poverty, and lack of knowledge, many women in Mrs. X's community gave birth at home. Some told stories of being treated harshly and disrespectfully by the hospital staff. Some were expected to pay bribes. Mrs. X had also planned to give birth at home, but then she developed a life-threatening complication. She started to bleed. If Mrs. X had been referred and had transport in time to go to a hospital with facilities for providing comprehensive emergency obstetric care, such as equipment, well-trained staff, and enough medicines and blood, her life, and that of her baby, might have been saved. Mrs. X could have lived to raise her children. After the long delay in finding transport, Mrs. X was eventually admitted to the hospital, where, due to the lack of resources, she and her baby died. Along the pathway of her pregnancy, Mrs. X faced barriers that prevented her from receiving the care she needed. Each could have been removed. And yet, many or all of these barriers remain along the roads taken by women today. Mrs. X could be any woman. Your sister, your wife, your mother, your daughter, you. It is up to all of us, no matter where we live, who we are, or what we do, to help remove these barriers for Mrs. X and the millions of pregnant women like her. As individuals, we can lobby for better healthcare and equal rights for girls and women. As communities, we can make sure our pregnant women are informed and cared for. We can organize local education, support, and transport for our mothers. As healthcare workers, we can provide quality care in a respectful environment, and we can continue to open the files and learn the lessons from mothers like Mrs. X. As local health planners, we can provide high-quality maternity and family planning services that reach out to more women. And as politicians and policymakers, we can strengthen human rights. We can improve education for girls and women, and we can provide the resources for better, more effective healthcare services across the world, wherever they're needed, now.
When I spoke about the maternal death rule, I was not looking forward to visiting the scene 25 years later. I expected that it would soon have become deserted. Progress has been made, but we fell far too short of our expectations. The maternal death rule is still busy with this one-way traffic, and still several hundreds of women in the prime of their lives are to be found lying dead by the side or at the end of it every day. But all of us who believe in the beauty of the dream of safe motherhood for all are not giving up hope. We are inspired by the success already achieved in several countries. We call upon all who care, men and women, from all over this world, rich or poor, in the north and south, to join and play their part. Safe pregnancy and childbirth, a joy, celebration, and pride for women should be a basic human right and not a tragedy in a 21st century world.
Thank you so much, Dr. Nkatha, for running that video for us and for setting the pace for this webinar. I would like to welcome all our participants from all over the continent to this Helen Kanzira Memorial Lecture 2021. And our theme for this lecture today is the impact of the COVID-19 pandemic on sexual and reproductive health rights in Africa. I would now like to welcome Professor Winfred Kamau, Dean, School of Law, University of Nairobi, to welcome us officially and to open this webinar. Thank you. Professor Kamau, over to you.
Thank you very much, Dr. Meroka, and good morning, everyone. It's a pleasure seeing every one of you this morning. And on behalf of the School of Law, University of Nairobi, I wish to very warmly welcome you to this year's Helen Kanzira Memorial Lecture. The School of Law is pleased to host this lecture in 2021 in partnership with the Center for Human Rights in the University of Pretoria, who have generously supported this lecture. And I do wish to recognize the presence of the director of the center, Professor Franz. I'm still trying to pronounce his name correctly, but thank you very much. We really appreciate your support. And as Dr. Meroka has mentioned, the theme of this year's lecture is the impact of COVID-19 on sexual and reproductive health rights. I think it goes without saying that COVID-19 has really changed our lives, probably for good. Probably we'll never get back to where we were. But I think what we realize is that COVID-19 has also exposed inequalities in society and has also exacerbated in vulnerabilities. people who are vulnerable. And I think therefore the topic of sexual and reproductive health rights and the impact of COVID-19 is really relevant to us at this time. And we are very happy to have a team of the keynote speaker, comprising the keynote speaker and Dr. Muteshi Strachan. Karibu sana. Thank you so much for gracing this occasion and agreeing to be our keynote speaker. We also have our colleagues from the University of Nairobi School of Law who will be introduced, and thank you very much also for joining us. And to our participants, I'd like to say a big thank you for coming in. Welcome on board. We look forward to a very vibrant discussion and great discourse in this lecture. So thank you very much and wish us all well. And I guess I can say then that the webinar or the lecture is officially open. Thank you very much.
Thank you, Professor Kamau, for officially opening the webinar and welcoming all the participants. I would now like to welcome Professor Franz Felden, who will also take us through the objectives of today's webinar and also give us a brief of who Helen Kanzira was and also tell us why we have this memorial lecture every year in her honor. Professor Franz Felden, as we say in Kenya, karibu sana. Over to you.
Asante sana, and good day to everyone. Dear moderator, dear Professor Kamau, and all participants. It's my privilege to say a few words. The Helen Kanzira Lecture is an annual lecture on sexual and reproductive rights in Africa, as we heard, and it is held within the framework of a consortium of 13 African universities that together present the master's program in human rights and democratization in Africa, the HRDA program. The University of Pretoria, where the center is based, and I am, and the University of Nairobi, where this year the hosting takes place, are part of this network, which stretches from the far east, that is Ethiopia, with Addis Ababa and Mauritius being partners of this network, up to the west, where we have the Université Gaston Berger in Senegal. Helen Kanzira was a graduate of the HRDA program. She studied towards and obtained the degree in 2000, which is the first year that the program was presented. This makes her one of the pioneers, the first of a group of about 30 bright African minds that would over the next 21 years grow into a formidable network of human rights professionals making a difference across Africa and further internationally. After completing the program, Helen returned to Uganda, where she applied her knowledge and skills to advance human rights. Sadly, and far too early, she passed away in 2007 due to complications from childbirth. While we then now mourn her untimely loss, we also honor her memory, her vibrancy, her humanity through this lecture. The inaugural Helen Kanzira Lecture was held in Pretoria at the University of Pretoria in 2011. And after 3 years of taking place in Pretoria, the hosting of the lecture has now started to rotate among the HRDA partners. Over the last decade, the lecture had taken place in West Africa, University of Ghana, University of Lagos in Nigeria. It had taken place in Southern Africa at the Universidade Eduardo Mondlane in Mozambique and at the University of Venda in South Africa. And it had taken place in Uganda at Makerere University, and that would be in East Africa, the region to which this lecture now returns in an online format. With an annual theme focused on contemporary aspects of women's sexual and reproductive rights, the lecture provides an opportunity for taking stock, for reflection, and to set priorities. It is a constant reminder, a recurring wake-up call, if you like, that maternal mortality can almost always be prevented, and that women's sexual and reproductive rights should be prioritized in policy making and implementation. We should recognize that much has been achieved since Helen completed her studies in 2000. The maternal mortality rate, obviously the number of deaths per 100,000 births in sub-Saharan Africa has decreased from around 870 at the time, 2000, which has a clear commitment to sexual and reproductive rights in its Article 14, was adopted in 2003 and entered into force in 2005. Today, 42 states have become party to the Maputo Protocol, of which Kenya is one, having ratified that protocol in 2010. Article 14 of the protocol has also become the basis for the first two general comments of the African Commission on Human and People's Rights. And the Commission further in 2008 took the important step of action and for accountability. Notably, this resolution precedes and influenced the adoption of a similarly focused resolution by the United Nations Human Rights Council in 2009. We have been privileged and honored over the years that seasoned experts in the field have been presenting this lecture. Retired President of Ireland and High Commissioner of Human Rights, Mary Robinson, was the one to give the first Helen Kanzira Lecture. She was followed by Dr. Navi Pillay, another former High Commissioner for Human Rights. And other lecturers include the First Lady of Mozambique, Dr. Uswara Nyusi, and the President of the South African Court of Appeal, Justice Mandisa Maya. To the Dean of the School of Law, University of Nairobi, and the team, thank you very much for taking the initiative of hosting this year's lecture and for your dedicated professionalism in setting it up. The theme on which the lecture this year focuses is indeed very relevant and timely. We very much look forward to this, the 2020 Helen Kanzira Lecture. Thank you very much.
Thank you very much, Professor Felden. We are very honored to be hosting this year's memorial lecture. And we have a panel, a great panel, who will take us through the lecture. I would just like to introduce all of them and then hand over to them to take us through the lecture. Our keynote speaker for today is Dr. Jacinta Muteshi Strachan. And Dr. Jacinta Muteshi Strachan is an expert in gender equality, women's rights, reproductive health rights, with over 25 years experience. She has worked as a researcher, program manager, and advisor in this particular area. And Dr. Jacinta Muteshi Strachan is currently the team leader of an FCDO-led program, 5-year program on the African led movement to end FGM in Africa. Previously, Dr. Jacinta has served as the first chair of the National Commission on Gender and Development in Kenya, and she has also served as the director of the board of the Kenya Human Rights Commission. In 2006, she was appointed by the president of Kenya to the Committee of Eminent Persons that helps facilitate Kenya's constitutional review process. She has also served on the task force for the implementation of Kenya's Sexual Offences Act and on the board of the consortium of the National Health Research Consortium. which was created jointly by DFID and the Wellcome Trust to improve the quality of research in addressing health and development needs in Kenya. Dr. Jacinta Muteshi Strachan holds a PhD from the University of Toronto, and she also served as the first chair of the National Commission on Gender and Development in Kenya. We are very honored to have Dr. Muteshi Strachan as our keynote speaker for today. On the panel, we also have Professor Patricia Kamerimbote, who will be one of our discussants. Professor Patricia Kamerimbote is a legal expert. She is a gender and women's rights expert. She has served as the Dean of the School of Law, University of Nairobi. Professor Mbote is also a senior counsel, and she is a full professor at the University of Nairobi. She has written and researched widely on the area of women's rights. And we are really honored to have Professor Mbote, who is a senior scholar, to take us through this discussion today. On the panel, we also have Naomi Njoguna. Naomi Njoguna is our colleague at the University of Nairobi School of Law. She holds an LLB from the University of Manchester, an LLM from the University of Manchester, and she is currently a PhD candidate at the University of Leicester, and she's also an advocate of the High Court of Kenya, and she teaches in the areas of labor law, health law, policy and ethics at the University of Nairobi. And she's also a pro bono lawyer with Kelin. And Kelin, for those of you who have interacted with Kelin, is an organization that does a lot of work around the area of health law. And Dr. Njoguna's PhD is actually focusing on this area of medical law and ethics. And therefore she is an expert in this area. And we are very, very honored to have her as well. So without further ado, I would like to welcome Dr. Jacinta Muteshi Strachan to deliver this Helen Kanzira Memorial Lecture 2021. Dr. Jacinta Muteshi, over to you. Welcome.
Good morning, Agnes, and thank you very much. I may need some help projecting. Let me turn this on. Thank you. Thank you. So let me begin by saying that I feel incredibly very honored to have been invited to make the keynote on the Helen Kanzira Memorial Lecture. And it's also with much pleasure that I am participating today, because it's been an opportunity also to be brought back together with many old colleagues and friends who are in this meeting or on this panel. So the focus of my presentation is on the impact of COVID-19 on sexual and reproductive health rights in Africa. Because what COVID-19 has done is provided us with a new opportunity to look again and think about these issues. Next slide, please. So the outline of my presentation will be to first generate the narrative around what is sexual and reproductive health rights, so that we are at least on the same page with regards to how we're discussing this very pertinent issue today. And I also want to raise a discussion around what does it take to ensure SRHR, and more so, I think, given the very short film we just saw, that very powerful film, which in my mind, and I'm sure in the minds of many of you, continues to demand that we pay attention to the continuing issues, concerns, and existence of this issue. These barriers have not ended. The issues raised by that film continue to persist into the present. And with COVID-19 emerging, what then have been the consequences, and several consequences and concern continue to bedevil this work for us. And then I will conclude with some reflections on moving forward, and these reflections indeed share it's an opportunity for me to share what colleagues and others in the field are bringing forward around this work. And then I'll conclude with an emerging good practice that's coming out of the organization that I'm currently affiliated with. Next slide, please. So sexual and reproductive health rights. When we talk about these rights, what do they actually mean and what do they encompass? And beginning with definitions is very important because I think it gives us an opportunity to reflect on, does the language, do the provisions continue to speak to the issues that are of concern to women in this area? Because these rights are to encompass the right of all individuals to make decisions concerning their bodies and reproduction, free from coercion and violence. And it's therefore a very integral part of how we achieve our shared global development goals. And I think, as was shared earlier, these global commitments have become treaties and consensus documents, beginning with the ICPD in 1994 to the Maputo Protocol. Now we are continuing to say these issues remain key. These issues remain issues that we must continue to address. And more so also now, as we've paid increasing attention to adolescents, we are beginning to see, in fact, that these have become or remain critical issues of concern. Because now with the adolescents, we see adolescent births, we see challenges for them in accessing services, and HIV has compounded issues for adolescents around sexual and reproductive health rights. So those disparities, even though yes, there's been improvements, we continue however to say that we remain challenged with these risks that both adolescents as girls and as women we face. Next slide, please. So what does it take to ensure sexual and reproductive health rights? Key is that we need to ensure that there is access to health services that will and can provide what I am highlighting there on those slides, all the various categories that there is a consensus and a global agreement that these are the key categories of ensuring the sexual and reproductive health rights of women. And we begin with family planning services, counseling, information and education on human sexuality, reproductive health. And increasingly now, we also know that it's important to think about responsible parenting and the discouragement of harmful practices in the kinds of services that we need to ensure will facilitate or enable sexual and reproductive health rights. Antenatal, postnatal and delivery services, health for infants, treatment for reproductive tract infections and sexually transmitted diseases, safe abortion services where they're illegal, as well as the management of its complications, prevention and appropriate treatment of infertility. And we're increasingly beginning to realize also that there need to be systems in place that respond to breast and reproductive system cancers and HIV/AIDS. And where those systems are not in place, then the possibility of referrals for such care. Next slide, please. So with COVID-19, we're beginning to see increasing challenges to our ability to ensure to facilitate access to those services that I just listed. Beginning last year, March 11th, when the World Health Organization declared COVID-19 as a global pandemic, there have been immediate consequences given this pandemic outbreak, consequences for the issues we're here to talk about today. The first and most immediate important consequence is there's been huge demand and a consequent heavy strain on health systems. The second immediate consequence has been that we have had societal responses to the pandemic, also with consequences such as the local and national lockdowns, the physical distancing, the travel restrictions, with consequences for economic slowdowns and with consequences with regards to severe disruptions in care or the redirecting of resources and services from sexual and reproductive health rights. And let me break these down a little further. Let's look at the next slide, please. So what are these emerging concerns? An immediate one is we saw the adverse effects on the supply chain of contraceptive commodities and the disruption of the manufacture of these components is one such example, but not just in terms of that these are disrupted, but also in terms of that even in transporting these contraceptive commodities across the world. So there were those disruptions that began to happen. The other major disruption that I want to flag here is that equipment and staff involved in the provision of sexual and reproductive health services were also, or we saw in many instances, begin to be diverted to fulfill other emerging needs, other critical emerging needs, in fact. The consequences were that in many areas did close, or people were reluctant to go to health facilities for sexual and reproductive health services because of COVID-19. And many governments were restricting people's movements to stem the spread of the virus. And that very much linked to the point above, which meant that people's access to services became also very hampered. Next slide. I want to share here, because I think these articulate really well or very eloquently what some of those consequences looked like. So last year, in 2020, many schools were closed. The consequence of many of those schools being closed, I think we haven't even begun to think about and reflect what that will mean for a particular group of young people. Young people got HIV, STIs, contracted diseases. School closures and economic insecurities exposed so many girls to sexual activity and sexual violence from opportunists. In some cases, parents decided to withhold provision of certain commodities to their girls, like sanitary pads, so they could get essential items like food. Shared this example from Uganda. An example a little further afield from Nepal. Of the nearly 2,700 young people across Ghana, Indonesia, Kenya, Nepal, Uganda, and Zimbabwe, more than a third of young people felt more vulnerable to harassment, sexual and physical, emotional, or financial abuse than before COVID-19. An example closer to home, Lamu County, reported a reduction in the number of pregnant women attending health facilities since March 2020. The health facilities used to serve at least 50 pregnant women and young children daily. The number has reduced by half as women fear contracting COVID-19. And this is particularly worrisome given the film we saw at the beginning of this lecture today. Next slides, please. Again, some other, I think, concerns eloquently shared. From Mexico, the General Director of the National Center for Gender Equality and Reproductive Health. Today, with the pandemic, we've seen a peak in maternal mortality caused by a lack of access to services. A real concern because we had begun to make inroads. We'd begun to see some successes with regards to the management of maternal mortality. The other, COVID is indeed a crisis with a woman's face. We see an upsurge in gender-based violence, in child marriage, in adolescent pregnancy, and as barriers are thrown up to the normal, protective, sexual, and reproductive health services. And the statistics before COVID were already bleak. It is shocking that only half of women are able to take essential decisions about their bodies. We're already in an era of incredible pushback against gender equality, sexual reproductive health and rights, and bodily autonomy. The COVID pandemic showed us that we really have to act now because these concerns have been compounded now. Next slide, please. So what have we begun to think and do with regards to responding to the incredible new harms and violations that are occurring as a result of COVID-19? Some reflections from the literature, and these slides will be available and you'll see and have access to the sources of much of this work. So given the risk of withdrawn or diverted resources to respond to COVID-19 that we're seeing, we see a need to increase resourcing to mitigate the impacts of the pandemic. But in this particular point here, the focus is actually on violence against women and girls, because one of the things that we know was particularly acute given the confinement, the confinement to homes, the fact that women were not able and girls able to access services anymore, and just the challenges of being constrained, we've seen a rise in violence against women. And that violence, that increase in violence against women as a result of COVID-19 is beginning to bring attention to the need to also respond to GBV as well, gender-based violence. Not only in terms of prevention, but also more broadly with regards to SRH services, testing, treatment, and care. COVID-19 restriction measures led to violations also of rights, especially to the most vulnerable. There's increasing evidence around this, particularly for those who are rural, who are poor, who are disabled, and conflict-affected communities. And therefore, this is a group that we're also going to need to pay attention to when we think about what do we need to put in place in terms of efforts to mitigate COVID-19. Given disruptions to supply chain, it's again about calling on governments to ensure that measures are in place to ensure continued access. And lastly, but not really lastly, but lastly in the sense that not to forget that it isn't just simply about do we ensure access to services, do we ensure access to commodities, but the much larger issue, the more broader issue about how do we ensure and recognize the importance of empowering women and girls, continuing with the work around respect for women and girls' rights and their fundamental freedoms, because really the promotion of sexual and reproductive health rights is dependent on the promotion of gender equality. And to achieve that goal in a way that are sustainable will require that we're not just addressing women, but also that we're addressing or making efforts in terms of our interventions with the communities in which they live, paying attention also to the fact that women are not simply alone in terms of the kinds of decisions that need to be made, but that they're also in relationships that might hamper their ability to make life-saving decisions. The need to pay attention to the fact that our issues as women with regards to sexual and reproductive health rights are located or situated within the broad societal decisions also that get made with regards to our collective as well as individual rights. Next slide, please. And final reflections from the literature on this, that there's need to use the opportunity created by COVID-19 to place sexual and reproductive health rights firmly at the top of public health agendas. And what would that actually look like? It would mean paying attention to the macro, to the meso, as well as the micro levels in terms of what that intervention would look like. I want to bring particular attention to the macro level here, because here we're talking about governments. And often you'll hear, and I've written it on the screen, the need for political will. And often I think we don't think about, but what does that look like? What would that actually mean? Political will needs to look like that we, in fact, are empowered to act in the sense that leaders, decision makers, are making concrete commitments, that we hear and can see these concrete commitments. And these concrete commitments are aligned with resources, not just financial resources, but human resources, and increasingly in modern times, as we can see, technological resources as well, because that is what actually would support and make real what political will and commitment looks like. There is also attention being brought to the fact that many of our countries in the region are beginning or seeking to expand universal health care. That expansion of universal health care might and will provide the opportunity to think about how do we incorporate sexual and reproductive health rights. At the national level and at subnational level, those macro level commitments need to be drawn down, need to be translated and operationalized as well. At the micro level, we're talking about now individual women and girls and how they become empowered, supported to be empowered in order to be able to actually demand these rights, as well as be able to feed into how those demands get articulated, designed, and delivered, and held accountable or see the holding up accountable by those who actually provide those services and access to those services. Next slide, please. So I want to share, just in closing, a good practice example. My organization, Options Consultancy Services, has recently launched a program called Women's Integrated Sexual Health, or Wish to Action program. And this particular example I want to share is one where we're providing technical assistance that creates an enabling environment for sexual and reproductive health and family planning services. But particularly, it is to increase the national ownership around sexual and reproductive health and family planning. It's being undertaken in 5 countries: Malawi, Madagascar, Zambia, Tanzania, and Uganda. But I want to share this because I think there's some key takeaways for us. One, this program seeks to create a favorable environment for policy and planning around sexual and reproductive health rights. It's seeking to improve the public response and investment in these rights, and also strengthen the stewardship of work, particularly ensuring that that there is the provision of quality services, and critically and most importantly, that there is accountability systems that track what is happening, that ensure that indeed the need is being met. And the key takeaways for me here that I share is that in the COVID era, what has been really interesting and important about this initiative is that COVID has been an opportunity. So in a sense, the pandemic has brought attention to the fact, what can we do? What do we need to do? What in fact must we do given the pandemic? And what it has done, and this is the takeaway, it has provided us a new opportunity for policy making, a new opportunity to engage with governments and bring attention to sexual and reproductive health rights. And particularly the opportunity is that there are new concerns emerging because of the pandemic. It has also presented the opportunity for us to think a little more about what does it take to ensure that the systems that need to respond are better prepared and more resilient. Because clearly, as we saw in 2020, they were not prepared to respond. We've seen and continue to see now in some localities, they're actually not able to respond, particularly to sexual and reproductive health rights of women and girls. And opportunity for stronger government stewardship in allocating funding for contraceptive commodities. So COVID in this case, with this example, has been, or at least the opportunity has been taken to reflect again, to think again about how do we deliver on those categories that you saw in my first slide, those categories around sexual and reproductive health rights that we articulated in ICPD in 1994, and that we still say continue not to be fully met, and that we still say we need to think about how can we be more creative in our responses so that indeed we are ensuring the lives of women and girls and the well-being, not just lives, but the well-being of girls and women. And final slide. Thank you very, very much. I want to end with this quote by a Kenyan researcher. Countries need to ensure that there is proper balancing of resources and priorities so that not all human and capital resources are geared towards COVID-19 efforts at the expense of other health service provisions. Thank you very much. I look forward to the discussions.
Wow, thank you so much, Dr. Jacinta Muteshi-Strachan. It was very, very interesting listening to that very detailed keynote address on the impact of COVID-19 on sexual and reproductive health rights in Africa. Thank you so much, Dr. Jacinta. Dr. Nkatha, do we want to do a virtual clap for Dr. Muteshi-Strachan?
That would be great, but you're the expert on that. We can do that.
We can do a virtual clap. I don't know how innovative we can be this time, round, but I don't know, because it's we are on webinar mode, so not everyone might be able to participate in the clap. But for those of us on the panel, if we could, Dr. Nkatha, would you like to lead us? Would you like to do fungua? Which one do you want to do?
The up one. I think Naomi is ready to lead us on the up, clap, clap, clap. Okay, Naomi.
Okay.
Katha, you're putting me on the spot, but if everyone could, I don't know if everyone could turn on their videos, or those who are able, and then we just rub our hands together, and we then send the flowers. Send the flowers. Thank you, Dr. Muteshi.
Thank you. Thank you very much. Thank you very much.
Thank you so much, Dr. Jacinta Muteshi-Strachan, for that. We really appreciate. And now, without further ado, I would like to welcome Professor Patricia Kamerimbote to make her remarks and to give a response to the keynote address. Karibu sana, Professor.
Thank you very much, Dr. Meroka. Thank you very much, Dr. Strachan, for this very, I think when you hear about sexual and reproductive health rights after watching Why Mrs. X Died, it's a very overwhelming subject. And I think when you look at it within the context of COVID, it is even more overwhelming. So what I'll do is just throw out a number of issues, just responding to some of the things that have been raised in the lecture. In essence, I think if you look at COVID-19, it found us how we were. I mean, if our sexual and reproductive health rights needs were unmet, then it occurred within that space. And it actually also found us, I think if you remember last year for Kenya, for instance, and a lot of the East African countries, we were dealing with locusts. And in our region, hunger is really never very far away from us, the threat of terrorism, and actually becoming broke because you fell ill is also not unusual. And then, of course, when COVID-19 came, it didn't ask intimate partner violence and gender-based violence to take a break. And so we are finding ourselves dealing with critical issues, and then the systems that help us deal with those are actually, they are stressed by this situation. And in fact, I think it's the UN Secretary General who said that gender equality, women's rights are essential to getting through the pandemic together, faster recovery, and building better future for everyone. So in essence, it's important to carry men and women along, because their experiences of COVID and their responses to the COVID-19 pandemic have been shaped by the roles that men and women play. And in fact, your capacity to be and to do things for many men and women is a factor of whether they are indeed men and women. And I'd like to suggest that the COVID-19 pandemic within that context is a pandemic within pandemics. And beginning and going back to why Mrs. X died, the social determinants of health, that is the conditions in which people are born, grow, live, work, and age. And all these have gender nuances. So when you talk about the first one, economic stability, employment, income, medical bills, or you talk about the neighborhood and physical environment, housing, transportation, safety, education, the whole question of literacy, food, hunger, access to healthy options, community and social context, the social support networks, stress, discrimination, access to healthcare, health coverage, provider availability, quality of care, provider linguistic and cultural competency. All these are things that we deal with, these social determinants of health. They have gender nuances because they affect men and women differently. And the pandemic comes within a context where we are moving. I mean, even as we talk about universal healthcare service provision, we are moving along, but we are not yet there. So COVID-19 impacted on the determinants, and I think Dr. Muteshi has talked about the limited access to healthcare. First of all, people not going to hospital because they fear contracting COVID, but on the other hand, because the healthcare systems are overwhelmed. And of course, the sexual and reproductive health rights of women were specifically affected because in certain parts, for instance, of this country, women stopped going to deliver children in hospital. And that again was a clawback on the gains that had been made in maternal and child health. I think the other way in which these determinants become a pandemic within a pandemic is the social stress that resulted, and which led to increased domestic violence, sexual and gender-based violence, and intimate partner violence. And this is on account of a number of factors, for instance, the closure of schools and offices, the fact that people work from home, and therefore they are much closer than they would ordinarily be. And then you have closure of worship spaces. Those would be spaces where people would go to distress. But now when they are closed, people have to stay at home. And I think for men, the closure of bars and other social spaces where they would be able to park before going home to sleep. And this again makes the context for sexual and gender-based violence, intimate partner violence more. I think the other way in which the COVID-19 pandemic is a pandemic within a pandemic is when you look at the responses, the curfews, cessations of movement, one, inability to carry out economic activities that again affects people's capacity, say, to pay for healthcare services. And also the fact that with the limited movement, access to hospitals is limited. I think that was raised in the lecture quite explicitly, but also unplanned pregnancies, and unplanned pregnancies also for underage girls. Then there is also the limitation of access to rights. When you look at the human rights-based approach, and you're looking at access to health, you're looking at services that are accessible, acceptable, adequate, and quality. But this was, the delivery of this was really affected by COVID-19. And actually, even when the rights are violated, because of the limitation on access to courts, again, even vindication or the claim for rights was also really affected. So in essence, my final take on this is that if you have gender equal societies, they would be able to deal with a crisis like COVID-19 much better, because like has been said over and over again, the COVID-19 pandemic is a threat amplifier or multiplier for both men and women, and leads to clawbacks in rights, whether you're talking about sexual and reproductive health rights. I think we heard about the spikes in female genital mutilation, unplanned and underage pregnancies within a context where people's economic muscle is really, really constrained. And then, of course, the limitation on access to healthcare services. And within a context where you have poor health-seeking behavior. I think, especially in certain communities in this country, there are differences in the way men and women seek health services. And also for those difficult to reach, if you didn't have access to healthcare services, with this constrained access because of the burden on the healthcare providers. You're talking here about the poor, the vulnerable, and stigmatized populations who even at the best of times have to go to seek health care services at night. Those are very affected by this pandemic within a pandemic, within the context of the social determinants of health. And finally, I think building back better will require healthy men and women, and sexual and reproductive health rights is a critical plank of building back better. Thank you.
Wow, thank you so much, Professor Mbote, for giving us the angle on masculinity and a pandemic. We are in a pandemic within a pandemic. It's always, for me, very refreshing to listen to you, Professor. Dr. Nkatha, shall we send Professor Mbote some flowers as well? Let's do some flowers. Professor, receive our flowers. Thank you so much. Thank you. We appreciate. I would now like to hand over to soon to be Dr. Naomi Njoguna to also take us through and to give her remarks as a discussant from the point of view of health law and medical ethics. Dr. Soon to be Dr. Naomi Njoguna, karibu sana.
Thank you, Dr. Meroka. And thank you very much, colleagues, and particularly Dr. Muteshi, for your keynote address, and just allowing me to plug into this conversation surrounding sexual and reproductive health rights during this time of COVID. And as Professor Mbote has rightly said, if we had challenges in Africa before COVID, they have been greatly exacerbated, during this time of COVID. And so as Dr. Muteshi, you were making your remarks, some thoughts, came to mind, which I think can also form the basis of discussions by everyone later. So in terms of SRHR, sexual and reproductive health rights, since they are a wider part of the right to health, these have been, as has been said earlier, they're contained in various international, regional, constitutional and domestic law frameworks in the continent. And in some constitutions, they are considered justiciable. In some would be just aspirational, aspirations that need to be met. But regardless of where they are, the importance, as Dr. Patricia said, is the importance cannot be understated of these rights. And I think one of the things that came to mind as you were speaking is the fact that there are two distinct rights, actually, from a right to health perspective. Sexual and reproductive health rights are usually lumped together, but they're actually two separate and interrelated rights. And sometimes sexual rights are kind of the content and the issues surrounding sexual rights can actually get lost in the conversations about reproductive health rights. They are distinct but separate. Yeah. And so according to WHO, for instance, they talk about sexual health as that state of physical, emotional, mental, and social well-being in relation to sexuality. And sexuality covers a number of things, and it's not merely the absence of disease or infirmity or dysfunction. And so there's there's a possibility, there's advocacy around the ability of people to live and to have pleasurable, safe sexual experiences, free from coercion, discrimination, and violence. Yeah. So the fulfillment of sexual well-being is related to reproductive health, but it is distinct. And I think that it is good for policymakers, implementers, regulators to actually have this in mind. I'm just remembering, even in our constitution here in Kenya, when it talks about the right to health, it distinctly does not state sexual and reproductive. It just talks about reproductive health, and the sexual part is left out, which I think is something that is an omission which should be corrected. So interventions need to consider this and various factors that influence individual sexual health should also be taken into account. But just going to your the part of your presentation about what does it take to ensure sexual and reproductive health rights, apart from the points that were brought out, I thought that it would also be good for us to consider perhaps what has also been addressed by Professor Mbote about the gender-based violence prevention, support, and care that needs to be taken into account and taken seriously by governments in terms of their policy interventions. But it's not just the violence that is between men and women, but also gender identity violence, where people, perhaps transitioning or, dealing with gender identity issues, but also violence against people of same-sex orientation. And I think, even sex workers are also part of that vulnerable group where gender-based violence should be, that conversation should take place. But also the social determinant approach that Professor raised. I think there also needs to be conversations around changing cultural and social norms surrounding sexuality. In this conversation about sexual and reproductive health rights, conversations about what is acceptable sexual behavior. So in most African countries, for instance, heterosexual sex is considered more acceptable than same-sex relations. And I think this also affects how sexual and reproductive health services are available or accessed, especially at a clinical setting, that there could be discrimination against people of same-sex, sexual orientation when they are seeking these kinds of services. Also within the African, communities, in some conservative communities, having multiple partners and having indiscriminate, unprotected sex, would not be acceptable, and people seeking services, for sexual and reproductive health may face discrimination. But in some more liberal communities, even within clinical settings, that is not considered abnormal, and education and counseling then can be undermined because it's not considered something that is abnormal, or that people need to change their sexual behavior. But also in the Mrs. X story, in the video that played at the beginning, I think one thing that came out very clearly for me is that there needs to be enhanced power relations and sexual bargaining power. And so, interventions need to be made around this, especially for women, who are not able to negotiate safe sex, for themselves in certain communities. Another thing that would ensure SRHR is a robust rights-based framework and environment where there is a recognition of the other interrelated human rights that affect the implementation of sexual and reproductive health rights, for instance, the right to life, the right to food and security, the right to confidentiality and privacy, security of person and non-discrimination, etc. But there also needs to be, states need to also consider the interventions for vulnerable, and marginalized populations, particularly women and girls with, disabilities, migrants, prisoners, refugees, and also the elderly. I think the elderly are usually forgotten in this whole conversation. And I see, sexual and reproductive health rights across a spectrum, from the beginning of life until somebody is really at the end. Some reproductive related cancers, affect midlife, middle-aged and elderly, and so this conversation needs to take place. But also, we also need an equally robust legal and policy framework and well thought out strategies. So in this instance, what comes to mind is not just health related laws and policies, but also civil and criminal laws around sexuality, which have an impact on sexual health. For instance, laws that criminalize same-sex relations, laws that criminalize abortion, and also laws that criminalize consensual sexual relations between adolescents. Yeah. I think those are conversations that need to take place around SRHR because of the impact that they have. And then we also have, as Professor Mbote said, access to justice mechanisms for those whose sexual and reproductive rights have been violated. There are various violations that we can talk about, including denial of safe abortion services, denial of contraception and family planning services, detention. In Kenya, at least, and I think even in Uganda, I've heard of cases that detention for inability to pay hospital fees, and also forced sterilizations. So in accessing justice, especially now that people are filing their cases online, there are quite a number of delays that take place. And so governments need to come up with policies where cases dealing with essential health services like sexual and reproductive health rights need to be prioritized and need to be given they need to be speeded up so that they can be decided quickly. And then also instituting of more strategic litigation as an advocacy tool. So apart from tort-based, negligence-based cases that seek compensatory justice, I think strategic litigation is one of the ways to go to ensure that there's awareness and to ensure that the outcomes of those cases would lead to legal reforms. There are some good initiatives that have taken place on the continent, the South African Litigation Center. And since the issue of adolescents came up, I think that one stood out for me because, in the, I think it is called the Uhoho primary school case, where girls and the boys who are suspected to have impregnated them were actually detained, and fined together with their parents, quite a punitive way of handling the situation. The South African Litigation Center took up this as a strategic litigation issue. And so, it brought out the kind of issues surrounding adolescent sexual and reproductive health rights. In Kenya, we have had, strategic litigation around safe and medical abortion issues, abuse and neglect, as well as illegal detention. But one thing that also stood out for me, and what is needed to ensure SRHR, is the working conditions of healthcare workers. And this, I think, is very close to my heart because my PhD thesis is actually about the psychosocial working conditions of healthcare workers within public hospitals. And the kind of stress and the mental health issues that healthcare workers face, is something that, if not dealt with, compromises availability, acceptability, quality, and accessibility of healthcare services to the general public. And studies have shown that there is actually a direct link between patient safety and the working conditions of healthcare workers. The lack of PPEs, especially now during the COVID time, the lack of proper facilities, the stigma around healthcare workers, due to COVID, them seeing their colleagues dying, patients dying. I mean, this is something that has caused a lot of mental strain on them. And not to mention the frustration that they face, the dilemmas that they face with the duty to treat patients and also the right to refuse unsafe working conditions. That dilemma that they face, some of them actually down their tools, they go on strike. In Kenya recently, there was a very sad story of during the strike period, a lady who actually had to deliver her baby at the gate of the largest, maternity hospital, Pumwani Maternity Hospital, at the very gate. Why? Because healthcare workers had gone on strike. Yeah, and so we may sympathize with the lady, but we also need to sympathize with the supply side of these services. And then, finally, we would talk about the financing for sexual and reproductive health. I think globally, financing is going down for sexual and reproductive health, services and products. And of course, on the continent, being an, countries being at the LMIC level, we need to really rethink our financing strategies. We also need to rethink accountability strategies, monitoring and evaluation of how these funds are being used. Corruption is rife within procurement, chains, as well as how the money is actually being utilized. Maybe going forward, as I finish, the pandemic having paralyzed many health systems, as Dr. Muteshi has said, perhaps this is a time to innovate and increase awareness and interest in digital health systems. I know this is, we are talking about resource-strapped settings, but I think it is doable. The only disadvantage is that governments seem to not tap into this resource. In Kenya, for instance, the government has increased the costs of mobile charges and internet bundle charges by up to 20, it's gone up from 15% to 20%, which doesn't make sense in, during this COVID pandemic, because learning is online, people are working from home and working online, so really internet costs should go down. And from a SRHR perspective, we can actually tap into digital platforms for digital counseling, especially for adolescents who would need a lot of confidentiality, and age-appropriate and friendly counseling services, and ordering even contraceptives online and things like that. So I think going forward, we may need to ask our governments to actually consider this as an intervention for sexual and reproductive health rights. Thank you very much.
Oh, wow. Daktari mtarajiwa Naomi Njoguna, thank you so much. For me, it was very enlightening listening to you. It reminding us really that health services are not always delivered in a value neutral setup, and there might be instances where there's stigma, there's discrimination. We also need to think about the psychosocial health of the healthcare providers. And really that is for me a stark reminder during this COVID pandemic. Daktari mtarajiwa Naomi Njoguna, if we could have you back on the screen so that we can deliver flowers to you. Please don't mind, I have some birds singing behind me. You could also receive the songs of those birds from an African field somewhere. Receive our flowers. Thank you so much. It was very enlightening listening to you. So we will now like to open up the discussion and have some question and answer. If we could have, you could either raise your hand or pop your question on the Q&A or on the chat, and we will read it. I can see we already have some questions. If you allow me to read through some of the questions, I can see Mary Goretti has given some comments on the chat. If I could just read through that. But I can also see we have someone who's, we have some comments on the chat, but you could also raise your hand. So Mary Goretti says the resonance of experiences across the regions is quite intriguing. I conducted a study in Nyando, Kenya, and the issues of predatory sex against adolescent girls increased during COVID-19. The reasons for this were the girls need sanitary towels, yet the parents are unable to provide. Food and other essentials are being sacrificed to provide these essentials for girls. Wow, all right. Do we have any other comments, or would any of the panelists? All right, I can see Mary Goretti saying this is Elizabeth and not Mary Goretti. Okay, all right, thank you, Elizabeth, for that. Do we have any other contributions? I think I will request Dr. Nancy Baraza to also weigh in on this conversation. Dr. Baraza, if you would, and I will take some questions on the chat. I can see we also have a question from Rose Onyango. Rose Onyango, if we could have Dr. Nkatha, may I request we have Dr. Rose Onyango included in the panel and she could ask her question. And Dr. Nancy Baraza, if you could also weigh in. I know this is a topic that's very close to your heart, and I know you have some some thoughts around that. If you could also weigh in. Do we have Rose Onyango?
Hi, everyone.
May I? Or thank you very much, Dr. Muteshi and the discussants. I think this is an important topic And I'm very, very happy that we are addressing the problem of sexual and reproductive health rights within the context of the COVID pandemic. I think very pertinent points have been raised by both the presenter and the discussants. But what stands out for me is the fact that I think this is an issue we cannot run away from. It is an issue that governments cannot afford to put on the banner. And in Kenya, in particular, because this is what I see around, but I'm sure research has shown that all countries are experiencing the same thing. I think it just exposed our government's unpreparedness for issues connected or related to sexual and reproductive health. And I'm happy that this lecture has brought those issues to the fore, and we should pick them up and probably see how our governments cannot relapse on them. Thank you very much.
Thank you so much, Dr. Baraza, for those remarks. We now will have Rose Onyango asking her question, and then we will also have Mary Goretti, but she tells me it's Elizabeth also asking her question. Rose, over to you. Karibu sana.
Thank you so much. I hope you guys can hear me.
Yes, we can, loud and clear.
All right, thank you. So a correction, I am not yet doctor. I am just Rose Onyango because I'm currently taking my undergraduate LLB at Kenyatta University. And I am working on my dissertation, which involves a research on the effects of public health crisis, pandemics like HIV and AIDS, Ebola, and now COVID-19 on sexual and reproductive health care rights. So a comment I'd like to make is that this pandemic seemed to continue to just amplify the kind of injustices that surround sexual and reproductive health care rights, where we keep on seeing trends that tell us that, you know, much as progress has been made in achieving sexual and reproductive health care rights, whenever we have public health crisis, all that progress kind of gets tramped upon because of government's unpreparedness and even, you know, lack of focus on sexual and reproductive health care rights. Yes, that is the comment that I wanted to make.
Okay, thank you so much, Rose, for that. We will now have Elizabeth appearing as Mary Goretti. Go ahead, please. Karibu.
Thank you, Dr. Meroka. Thank you, Dr. Jacinta, and all the who are presented on the women's health issues. Indeed, I just got a report here that over 100,000 girls were married in the first year of COVID-19. And this is really a worrying trend that all the gains we are getting are taken back. And we are now using COVID-19 as an excuse for all this which is happening. There is need now to go to the grassroots and see what we can do to salvage the situation. The numbers are worrying, and this is indeed too much for us to take as women. And there is need also to sensitize the government, because Jacinta talked about a goodwill from the government. There is need for that to be taken seriously, because if we lose girls like this, then we shall have a very poor nation in the future, because it is the girls, the women, who make the world. And if you cannot give them education, if you cannot give them good health products, then we are doomed. we are likely to repeat the story of Mrs. X. And I urge all of us here to really campaign towards ensuring that we have our girls protected, our women protected, so that we don't have Helen Kanzira joining Helen Kanzira, the lady we are celebrating today. Thank you very much, Dr. Meroka, and all the organizers. Thank you.
Thank you so much, Dr. Akinyi. Now you spoke, I know this is Dr. Akinyi from African Women. Thank you for those comments. Dr. Jacinta, I would now like to hand over to you to give your response both to the discussants and to some of the comments that the participants have made. I would also like to invite all the other participants, if you have a question or a contribution to make, you could raise your hand or pop your question on the chat or on the Q&A, and we will respond to it. Over to you, Dr. Muteshi.
Thank you very much, Agnes. Thank you. Some final reflections, not really sort of responses to the questions, but some reflections. The discussants, I think, have raised some really critical, important points, and I've actually started in the chat box to speak to those issues and reflect on those issues. I'm really actually glad that Naomi raised the fact that the sexuality component of that sort of sentence, sexual and reproductive health rights, very often disappears and is very rarely ever part of the discussions we have around this work. And as I say in the chat box, part of the reason it disappears is because in so many contexts, it remains, I mean, the issue of sexuality remains a taboo subject, or simply that spaces are never provided for women and girls to have these discussions, as if the issue of consent and choice and pleasure is not part of the vocabulary, you know, for girls and women. But I think there is work that's beginning to happen here, which is encouraging. But most importantly, I think it's good to be reminded, and I think that reminder will need to be sort of continually present, that when we open up discussions around sexual and reproductive health rights, not to forget that component around issues of sexuality. But of course, you know, we know the reasons why, in fact, it also does disappear, besides what I've just said, that we're still telling the story of Mrs. X. And this is why this continues to be a challenge for us, you know, that those concerns continue to be present. And so that conversation continues to be there. The other point I do want to raise is that, you know, when we often talk about how do we begin to mitigate, how do we begin to respond to the challenges we face around sexual and reproductive health rights, that to see them as not just about women and girls, but to see them also as about boys and also about men. And therefore, how do they become part of these conversations, the dialogue, part of the responses that are needed to be had? Because really it is male privilege in many ways that is at the root of many of the concerns that we're discussing today. It is part of the issue around some of the harms we've seen increase, such as gender-based violence during the time of COVID. And what COVID is doing is, I guess, flagging that here's another opportunity to bring these issues back to the table, because they have, first of all, they've disappeared, but more to even just say that these issues have not ended, that they must continue to be always part of our continuing discussions around how we ensure the rights of women and the rights of girls, given the challenges that continue to be present. Those are my reflections at this point in time on what I've been hearing and what has been shared. So thank you very much for bringing those issues on the table at this meeting.
Thank you, Dr. Muteshi, for those reflections and points that you have raised. I can see we have a question from Alette. And she asks, I will just read this. I would like to know what is your advice for women whose wombs have been removed during intervention without giving any consent? Because for some of us who went through medical intervention, we have signed consent forms without having time to read them, just because it's an emergency or it's a must. Can someone be held responsible for such an incident or violation of your right to sexual reproductive health. Soon to be Dr. Naomi Njoguna, I would want to hand this to you because it seems to be right up your alley. Would you like to take that, Naomi? The question by Arlette.
Yeah, thank you. Yeah, let me see if I can put on my, yeah, right. So thank you, Arlette, for your question. Wow. You know, from your question, it says, because for some of us who went through medical intervention, I'm hoping it wasn't an intervention. It's not this kind of intervention where you know, what you're describing has happened to you. But if it has happened to you, yes, in giving consent, you know, it's not just about signing the consent form. It is about having the correct information. The medical practitioner has to ensure that you have understood what kind of intervention is going to take place on your body before they actually touch you, before they actually do, you know, that kind of serious intervention on you. And in fact, the more serious the intervention on your body, the more that the healthcare team needs to ensure that you have understood what is going to happen to you, right? So yes, there is, you know, you can actually bring a case. It would be an issue of negligence, you know, in this case, because information has not been given to you, right? It would not be an issue of, say, battery, you know, where you've been touched without your consent, because technically you've given consent, but the consent has not been given with proper information, and that is why it is a negligence case. The healthcare practitioners have a duty of care to you to ensure that you understand the information. They have breached that duty, and harm has occurred as a result of that breach of duty. Yeah, so you can actually consult a healthcare lawyer to bring this as a matter of as a litigation issue. Yeah, thank you.
Thank you so much, Naomi, for that response. And I think also to flag that Kellen has a petition. Maybe Naomi, you could also weigh in and tell us how far that has gone, because there has been an issue of sterilization of women with HIV and AIDS. And there has actually been a constitutional petition to that extent, where women seeking healthcare services, they are HIV positive, and for them to access those services, they're then forced to undergo a sterilization. So what are those actually, some of those legal issues? Yes.
Yeah, you're definitely right, Dr. Miroka. The forced sterilization case is actually, I think, something that we need to weigh in on. It was actually decided that, you know, their constitutional rights were actually violated. I think if you want the citation, I'll just put it on the chat so that you know, you can have a look at it. But definitely, the issue of forced sterilization, I think that one would be different from this case where somebody has signed a consent form. However, also signing the consent form under duress, for instance, because in the Kellen case, some women were actually signing consent forms because the threat was that if they do not sign the consent form, they wouldn't be able to get formula, you know, for their babies. You know, as HIV positive mothers, they were being, you know, discouraged from breastfeeding, right? So they needed formula, and one of the threats was that sign this consent form, get the sterilization, and then you will get, you know, free formula, right? So that's another, you know, if you're bringing it under the constitutional within the constitutional framework of litigation, okay, you want to bring a constitutional petition, you also have a right if you are actually forced to sign the consent form under some form of either economic duress or physical duress. Yeah, thank you.
Thank you so much, Dr. Naomi Njoguna. Professor Mbote, I would now like to hand over to you to give your responses and your reflections on some of the points that have been raised. Over to you, Professor.
Which professor?
Oh, Professor Mbote. Professor Mbote.
Yes, Professor Franz Vilio, Professor Kamau. Okay, I think the discussion is clearly an octopus discussion, which brings in very many issues together. And what this then points to is the need for a broader debate. I'm sure Professor Franz can see what kinds of discussions we need to have. And these days, because we don't have to travel to Pretoria, we are sad about that, but we can discuss online, because these are the kinds of discussions that will grow the discourse, so that even as we talk about why Mrs. X died, there are very many potential Mr. and Mrs. Y's who could also die unnecessary deaths. So I think basically it's just an eye-opening discussion, and one that needs to be continued, so that we have the expression of voices that tend to remain masked and not heard. You know, when I was talking about the stigmatized, it reminded me doing research on HIV and AIDS, and women telling me that they were not taking their antiretrovirals because when they went to hospital, when they went to the comprehensive care centers, they came home with the ARVs, and the men took the ARVs. Of course, there's the whole question of you don't even know what your viral load is. So if you take somebody else's, it may not even be useful. But the more fundamental issue was asking the men, why don't you want to go to hospital? There is stigma, one. But the more fundamental one, which I was adverting to when I was talking about poor health-seeking behavior, the men said in their mother tongue, we do not want to clean the seats with our backsides. You know, the way you keep moving until your turn comes. And you can see that the gap between safe mothers and even good health can be as far-flung as just not wanting to be seen sitting down, but also your ego not allowing you to keep moving. And as they said, cleaning the seats with their backside. So I'd like to stop there, Dr. Maroka.
Wow, thank you so much, Prof. I think these are stark reminders. These are important conversations. I can see, I believe we are all thinking through these issues. We don't have any more questions on the chat, and so I would like now to just hand over back to Professor Kamau to take us through the remainder of the program. But I think in just giving my final reflections, we have had very, very fruitful discussions and engagements, and important reminders on these issues of sexual and reproductive health rights. These are not easy conversations to have, and it's quite a lot to think through some of these issues. So allow me to hand then back over to Professor Kamau to take us through the final part of this session. Thank you.
Wow, I can only say wow, really. This has been a most enlightening and engaging discussion. I have learned a lot personally, and I'm really grateful for this opportunity for us to share and exchange, thoughts and ideas. I think the discussion has brought to light the complexity of the issue. When we talk about the impact of COVID-19, one may probably think, oh, it's just a matter of health or a matter of the economy. But I think what this discussion has shown us is just the complexity of things and the interrelationship between even rights, the interrelationship between different factors, the economic, social, cultural, political factors, etc. And for me, as a scholar in education law and policy, I also am thinking about the role of education in this, area, and how can our education system help, right from the beginning through kindergarten to primary and secondary school, and even to the university. And even in terms of curricula, how do we ensure that curricula respond, to these issues? But education also more broadly, related to community type of engagement. And so I really want to say thank you very much to the presenters, Dr. Mteshi Strachan, and our discussants, Professor Kamerimbote and Ms. Naomi Njoguna, as well as a very able moderator. Thank you so much. And thanks to all the participants for being so actively engaged in this discussion. Professor Felden, as well as Ashwani, thank you so much, the Center for Human Rights, for making this possible. And I'm just thinking about, the role of the various actors, the role of government, the role of non-state actors such as civil society, as well as community-based organizations, but also the role of the academy, because we are in a space, the academic space, and what potential then this holds for research and academic engagement. And my hope is that the discussion would not end here, that it would continue in different formulations. And I am looking forward actually to next year's Helen Kanzira Memorial Lecture. I don't know who will be hosting it, but I'm already looking forward to it, because there is so much to gain and learn. So I think with that, I would just like to thank everyone really, and say I've enjoyed myself, but also learned a lot, and hope that these conversations can go on even further. Therefore, I'd like to just thank everyone. And with that, those are my closing remarks, but we are not over yet, of course. And so I'd hand back to the moderator for the next bit on the program. Thank you very much.
Thank you, Professor Kamau. And on that note, I would now like to invite Honorable Dr. Nancy Baraza to give us her closing reflections on this, which I think is important, but also to give us the vote of thanks. Dr. Baraza, karibu.
Asante, thank you very much. Just my boss, Professor.
Dr. Baraza, you're muted.
Thank you very much, like my boss, Professor Winnie, who has said, this has been very enlightening lecture, and I look forward to the next lecture. I think it is very issues, and to keep them alive, we must keep having, and I look for those few remarks. Let me perform my very, very privileged duty, and that to pass a vote of thanks for this lecture. Representatives from Center for Human Rights, University of Pretoria, that Professor Felden, Dr. Ashwane, and all the rest. The Dean of Law, University of Nairobi, Professor Winnie Kamau, our valued keynote speaker, Dr. Jacinta Muteshi, discussants, ladies and gentlemen. It is my privilege to have been asked to give vote of thanks on this occasion that marks this year Helen Kanzira Memorial Lecture. I echo every speaker that has emphasized the significance of sexual and reproductive rights, particularly in this era of COVID. And now the eminent present and discussants have reminded us gender equality and the empowerment of all not be possible without the realization of sexual reproductive rights. I, Dr. Nancy Baraza, on behalf of the School of Law, University of Nairobi, and on behalf, extend very happy vote of to guest speaker, Dr. Jacinta Muteshi, the distant Professor Patricia Kamerimbote, and soon to be Njoguna, to our partner, the Center for Human Rights, University of Pretoria, for making this lecture a success. Thank you very much. Asanteni sana, mbarikiwe. Thank you.
Thank you, Dr. Baraza, for that. And on that note, we now then, we have come to the end of our program, and we look forward to seeing you next year. Thank you and kwaheri.
Yes, before we end, I would like to just add my voice to Dr. Baraza's and Dr. Meroka's in thanking everyone, but also to recognize those who have worked behind the scenes. We've had an organizing committee made up of Dr. Evelyn Asala and Dr. Agnes Meroka, who have really worked tirelessly to ensure that this happened. And we also have had Dr. Nkatha Kabira help us with the logistics, and you can see how well it has worked. Dr. Robert Kibugi, one of our other colleagues, helped us, and also Davis Ndambo helped us with the publicity. So just to mention, they're very modest, you know, but it's good to just acknowledge. So thank you very much, the team that helped to make this possible. And thank you, everyone, and kwaheri. Bye-bye.